So it's time for you to practice your French. Is there francophones in the room? Is there people who like francophones in the room? It's a great honor for me today to present someone that I admire greatly, the wonderful and fabulous Joanna. And my name is Olivier Feller. I forgot to introduce myself. Joanne Otis has a doctorate in public health from Montreal University. She's a professor and director of the programs of first cycle at the UQAM, and she's interested in the promotion of sexual health and preventative health and spreading the knowledge in those areas. Since '91, her research has been on the factors of psychological impact and particular sexual transmissible infection, and also on the planification, the implication, and the cultural adaptation of intervention in the field of sexual health for key population. That is what is the work of Joanne Otis is to be implicated in the research in the community, and she's was given two different prizes in 2007 as an ally of the community. One in the fight against AIDS, the Claude Tourangeau Prize, and the Medal of the National Assembly from the Quebec government for being involved in the defense and the research of the rights of the LGBTQ plus communities. Furthermore, if you don't know Joanna, I had the opportunity to see her present in Montreal, and when she arrives in a room of gays, she is received as Madonna. So she's a rock star, and there she is. Hello to everyone. I am absolutely terrorized. It's really, if you want me to tell you about about how I feel right now. So at first I'm going to do at the Oscars, because I'm afraid to take too long. So first I want to thank the committee, the programming committee of the summit, of course, that gives me the privilege to come and share results and reflections with you. And it's absolutely amazing. And a big thank you to Michael Quad. Michael, yes. I know that he has a lot of patience, and his resilience to stress is absolutely incredible. I gave him the presentation the day before the summit. He translated everything. He was so patient. I arrived in my room and I had strawberries in chocolate, and thank you very much to have insisted so that I can do this presentation in French. So I'm really sorry, you're going to miss my sexy French accent. In French, I don't have one, but if I have one, it's from the North Coast. So it's quite a work for the translators. I tried to make myself understood. I'm going to try to not say that I'm going to paint myself in the corner or that I am moving like a... The interpreter has no idea what poltaltet means. So there. Another big thank you to Michael for the electronic toilet in my room. I was very intimidated. I'm very afraid that it makes me do things that I don't want to do. So my third, I'm going to be very serious at one point or another, but it's just because of stress. So now I'm starting to become a little more serious. So the third point on which I have to insist before starting presenting is to underline the privilege that we all have today to share these reflections on the unceded territories of the Salish people of the coast. Those are not empty words, what I'm saying. I was lucky enough to work for 4 years with elders from the Cree community in the Bay James. And I learned a lot from these people, especially about silence being an amazing tool of communication. But I could tell you a story at the end if we have a little bit of time remaining. It's worth it. For me, it's really important to acknowledge these territories. The fourth point is, like I said, I'm absolutely petrified. 30 years ago, there were very few people who spoke about the gay and sexuality of the gay population at the beginning of the epidemic, as if sexuality was exorcised from AIDS. And so I felt more legitimate to be a witness or someone who could transmit information. But today I feel not very legitimate. I feel the syndrome of the imposter. I don't know what I'm doing here to talk, to speak things that concern you. I am impressed with the quality of yesterday. I mean, I'm emotional. What the emotions that I lived through, the young investigator gay that we have been listening to. You're able to speak out, young gay men. It's amazing. So one day, I mean, I'm very touched that you ask me to be here and to talk about you. And I will do this in all, and I hope that what we'll be sharing will make sense to you. And if it doesn't, you tell me. And I also wish to thank you, because for the last 30 years you have allowed me to learn, and I'm very emotional. You have allowed me to learn, and what you have taught me the most is the meaning of the word resilience. And resilience is brightness. That is what I see here. I said to someone yesterday, I found him beautiful because that is what I saw, his resilience. And so thank you for having me allowed to live with this. So enough, niceties enough. Let's talk about boring things. My presentation is about numbers. And again, I want to tell you that beneath those numbers, there is a lot of people who have a soul, a heart, and a penis, sometimes not, and who want to have pleasure, intimacy, and what seems to be called, for me as a researcher, sometimes you cannot have an opinion for yourself. You need data to express yourself. So for me, these numbers mean what is behind those numbers and those stories that I can share with you. So don't worry about the numbers. I worry about them because I need them to lean on. But let's talk about the access to services for the LGBTQ plus communities. So is everyone with me? You know, I'm a teacher. I need feedback. Are you okay? So what I suggest is a three-step presentation. At first, we're going to come back on the context that is at the base of all that we talk about access to services. Talking about the Mobilise project, it's still the focus is access to services, and the data that I'm going to be speaking about comes from that. And the results that I'm presenting is like two sides of your glasses. The way gay men look at their needs and for health services and the obstacles that they encountered, and the other way is the point of view, and again is the way health providers and main gay men is what we really want for LGBTQ men. So there. My thing is not working. Oh my God, I'm so bad at technology. That toilet, honestly. So you react a little bit after. And so Mobilise is a research project participating with the community. There is pros and against, and pros like me, and there is people from the community and organizations and from the public sector, private sector, and all that. So I am going to spare you the list, and I'm going to talk about people who were involved in the project. So at first, it's not complicated. There is an overrepresentation of the people of the LGBTQ plus community in the data talk about mental health, violence, dependency, sexual health, ETSS, AIDS, and we cannot deny that AIDS is not dependent and that there is a syndemic, and the people that are vulnerable and who are typical of this syndemic have common factors that bring them to be vulnerable. And all that means that the coalition that was put in place at first in Montreal noticed certain things and said that, well, we cannot just work in the prevention of AIDS without dealing with the other health problems. So the importance of syndemia, and it is important that we have a perspective of prevention, a combined prevention, and we have to give people different options so that they can be happy in their sexual health, and we have to respect their way of living and what they enjoy, and we realize that we need private interventions, but that we have to attack the basic factors that are often organization or structural problems. So that is really the basis for our work. If you know Mobilise, you must have seen this graph 40,000 times. We know that we need theory, and that we found one that seemed to be logical, and this graph shows that the access to services from a point of view of the users, that is the bottom line. Somebody needs to realize that they need health services. They need to be able to find them, arrive there, and to stay within the system. That is everything that we see at the bottom: to perceive, to reach, to get, and to take advantage of it. Well, all this is beautiful, but we also need to work about the structures being able to absorb the health needs. For it to be able to absorb the health need, the services must be approachable. We'll talk about that later. Acceptable for someone of the LGBTQ plus community. You need to know that they will understand you and not judge you. You need to have services that are available and affordable, and be able to fill all the needs that I have. So what I am going to present you with is the point of view of the bottom line from the user point of view, and then the point of view of the system. Are you okay with this? Yes, Mrs. I am a school teacher. So just to tell you, with this framework, inspiring framework in Montreal, there is a coalition, an intersectorial coalition that was put in place, and on the community front, there were a lot of actions that were put in place. We got a website on the Mobilise project, and we have all the tools that we have developed on the website. We put in place teams. I see absolutely nothing. Am I reading French or English? It's English. Okay, English. So I'm going to go from memory. So citizen teams. So there is several people here who have participated, including Jonathan, who at that time was one of the leaders. And one of these leaders These people were not identified by their peers as leaders, but they were people who had a certain influence in the community and were noticed in order to reach trans people and different ethnic groups. So these people have received training. We had activities so that they went to their communities talking about reduction, strategy reductions, prevention, PEP, screening. All these people came and gave us all the everything they had heard in their community in Mobilise evenings. We put a survey online to gather the results and to give them back to the community during a community forum to talk about what we were talking about, what the obstacles were, and what we were going to put in place. And there was a community consensus that is just about to be finished that we will present to the government to talk about what the community needs as far as healthcare needs is concerned. You can see it's a very interactive process. As a researcher, my role is to give knowledge that will be used and useful for action. To publications is a secondary thing. We need to use data as a tool. So that is where data is produced, and then we use them for action. As far as the system is concerned, it is really, we did a map of the services to realize that problems were really linked to approachability, adequacy. In Montreal, there is everything. There is absolutely no reason for a LGBTQ person to have access to services. The problem is that everybody works solo, nobody works together, and it's not clear. So those are what we have to work on. So there is two things we have to work on. We're going to have to put a map out, and we have to present to the organizations, and with them the services, the picture that we present them must also make them think about what they wish to change. In each organization, they have priorities according to what they see, and the evaluation of the conditions to access. So in about 3 years, we should have a better integration and coordination of services. There is a lot of work to do, but I will talk about that a little bit later. So let's look about data. I can talk a little bit more length about the project, but I really want to talk about the results. So first, about gay men, that is about the online survey. We had about 1,000 participants on the online survey. 70% finished it. So the data is quite valid and representative of the reality, at least for those who answered. And that is interesting to look at. That is the most important slide, but I cannot see it. Oh, I see it here. So I keep speaking with you, even if I don't look at you in the eyes. So if you want, we can look at the middle line, the data in the middle. Can you see 64% for screening? Can you see that? So the logic is that the 64% that concerned 64% of the men have expressed the need for screening. And amongst these men, can you see the 5% above? Yes. Yes, ma'am. Good, good, good. I like that. That means that there is only 5% of the people who requested services who did not get it. That is very good news. So let's do the same for the rest. So if we look at mental health, I only have 31% who requested the services for mental health, but I have 19% who didn't get these services. So again, it is the demand and the need that is not fulfilled. And if we look at PrEP, 16% requested it, 27% did not get access for PPE. 5% only requested the services, and 17% did not get it. As far as addiction is concerned, 4% only have requested services, and very few people were able to get the services that they needed. And for everything that has to do with violence, it's even less people who requested services, only 2%, and 44% were not able to get to services. That is what we have to note, is there is a very big gap between the demand and access to services. But what is even more fascinating is the data that I put at the bottom. If you look at the bottom, we have, as far as screening is concerned, the good news is that 23% had STIS in the last 12 months. And you can see as well that 1 out of 3 men had unprotected sexual relations, if you exclude PrEP. So in the end, there is more people who went towards being screened, and the real need that is, it's probably even less. So that's good news. But look at all the rest. As far as mental health is concerned, and what we had in the survey, 1 out of 3 men were saying that they had precarious mental health. But it's good news. I mean, there's people are able to estimate quite correctly what they need. Don't know what that means, but you can see that services in mental health are not able to fulfill those needs. And then if you continue like that, it becomes even more impressive as far as the gap is concerned. Talking about PrEP, 29%, 1 out of 3 men are not eligible, whereas I only have 16% who asked for it, unless that got it. PPE is catastrophic, and there's the risk-taking for 1 out of 3, but I only have 5% who demanded it, who asked for it, and that is a very efficient measure. I mean, you know, and things aren't working quite correctly, but for the problem, addiction problems, it's a little bit the same. What we had looked at, it's 27% that have risky use, whereas only 4% requested services. As far as violence is concerned, it's even worse. 1 out of 4 reported domestic violence or violence in general as far as their gender is concerned, and there's very little demand. And we're going to come back on that, but there's really, we have to think about that, about the reasons why this is this way. If we look at quickly, we're not going to go through the whole slide, but the profile of the people who don't have their needs met, what comes out? Intersectionality, syndemic. Why? People who have not met their means are more at the non-francophones. For us, you're a minority when you're English-speaking there. It's not the same somewhere else, but anyway, here the language is a problem. The income, the fact that you can be a trans or non-binary or two-spirited, and that is really the problem of intersection that comes into play. And what you see is people who have more psychological distress, homophobia, internalized homophobia, who live. And if you look at the barriers, and if you want, we can look at, I always have problems with my left and my right side. The column here, it's good. Let's look at that. What we see is, as far as access barriers, is at first you don't know where to go. You have difficulty to finding information and to navigate. If it takes more than 2 clicks to get the information, well, forget it. And everything that we have tested takes more than 2 clicks. and also to find services that meets your personal needs. So what we see is that people who say that their needs aren't met, there are barriers that are important for at least 50% of them. Hey, James. No, Andrew. I'm so sorry, Andrew.
Take a look on that. Okay? La honte,
shame,
la culpabilité,
guilt,
la peur d'être jugé,
fear of being
la peur
judged,
d'être discriminé,
fear of
la
discrimination,
peur d'être outé,
fear of
la
being
peur
outed,
que ça reste pas confidentiel.
fear that it won't remain confidential, fear, finally, that of saying what your sexuality is. That's the major barrier, not just for those who are in a handicapped situation. We have work to do along these lines. To have shame in 2019, sexual rights exist, but we need to work on this. It's very important. In terms of other barriers, these would be more structural or organizational barriers, waiting time between the call and the appointment, difficulty in being available for some 90% of the population to attend the service between 9 and 4 from Monday to Thursday. It's not really a win-win situation. That's what is being shown here with some of these barriers. The question of cost, surprisingly, among all of the barriers that I've enumerated, yes, the question of cost is an issue, especially for PrEP, but it's not the main difficulty that has been encountered. And we'll show you ways to deal with that a bit later. And here, the final category of barriers that occurs once you're receiving the service, what makes you want to return or not. It has to do with the fact of not being involved in the decision-making, to not have had time to ask questions that you wanted to ask. Perhaps you didn't understand everything, it went too fast. But what we can see makes the difference between those who have their needs met versus unmet is that they appreciated being referred to another service. That's an important one. And the difficulty of being able to express one's needs. Because if I need screening, I want to know my status, but I don't want that to cause other difficulties. I have consumption problems. It's going. I'm doing tests here and there. What we can see that in terms of barriers, it's the same profile we saw earlier. Both people who have unmet needs and those who find they have bigger barriers at all stages of the access trajectory. It's a question of syndemia. So from this data, from the perspective of gay men, really there's this underestimation of this demand for services versus health needs. But what's going on, PrEP and PEP? Is it a lack of information? Are these only personal barriers? No, there are other types of barriers. But if we talk about violence and addiction, what a GBTQ plus person who doesn't feel legitimate to say they have been a victim of violence, that they don't not want to talk about their addiction. I'm thinking of what happens in the community in terms of banalization or normalization of consumption, of use, drug use. We need to understand why people use. And all of this needs to be dealt with before people can feel legitimate to request service. And then the second part is how the service receives you. So in general, so I also would say that if I have 64% of gay men, of GBTQ plus people who have been screened in the past year, in the population overall, it's not 64% that are going to go to health services. So screening is really the center. It's the entranceway into the system. And I don't understand at the present time the investigators. I have a good idea for you. You need to develop a simple, validated tool to allow, through 5 questions to any frontline worker, to detect the needs, to take the person as they are. And through these 5 questions, I can have a tool, an algorithm that will allow me to refer that person where they need to go. And the concept of no wrong door. We've seen that many people who have been able to achieve other services. So we really need to have these 5 questions in mental health, in violence, to have a referral system that's very integrated. And these data lead me to believe that there needs to be more investment in this area. Now we'll look more from the perspective on the system itself. This data comes from focus groups that we held in Montreal, Toronto, Vancouver, thanks to the support from Rotan in Toronto, McPherson in Ottawa, and I can't remember. I've almost finished. The time is almost up. Markle in Vancouver, Mayton helped us a lot, the Community Research Center here, to analyze this data. I want to thank all of those people, as well as the community groups that took part. The way of looking at this data, what we were looking for in the focus groups is what would an optimal or ideal service look like in terms of the 5 dimensions I just referred to. And I'll go very quickly because my time is running out, but I will say that in a few weeks, we're going to be validating all this material, and we're developing a tool that will start from this information and allow each team and organization to provide, to input its own judgment on the approachability and acceptability of these services. So this will allow for monitoring and decision-making, not for the purpose of evaluation, but rather a tool to allow access to services to improve. Sorry, I'm running out of time. Again, we have figures, statistics. Just to quickly explain, the little one that you see above, it's for men, the men who replied from the community, and the element mentioned there is really what is the most important, and it's ranked from 1 to 23. And for service providers, the same thing. The ranking is, the importance ranking is indicated there. Just to say that service providers and men in the community don't always have the same perspective. Big surprise. I'm going to go quickly, but if you want to improve access to your services, it's probably a good idea to take into account the point of view of your users. So in terms of approachability, how to make our services visible. A guy who's looking for something needs to find it. The information given needs to be clear. We've seen that any use using technology, ICT, and means other than technological, we must not only focus on one strategy. Not everybody is hooked up to the internet. Some of the more vulnerable populations don't necessarily have access. Local community work is very important. Community outreach. You can read this on your own time. You can read these lovely quotes. I'm not talking lies here. These are words that come from the participants themselves. Acceptability indicators are very important. What the men in the community find important? What are the means that will reassure me that it will be anonymous and confidential? How will the setting be set up to maintain confidentiality? How will the administrative procedures be borne out? Again, the place, the setting itself, how does it indicate to me that I will be welcome there and it will be treated confidentially? The reception I receive when I arrive, these are really the most important issues, and a clear description of the services offered and to what extent these services will meet my needs. In terms of availability and accommodation, it's really the quality of the information given in terms of the waiting time and so on, and the measures taken to provide appointments, to access the service, whether it's with appointment, whether it's drop-in, whether it's online, through text message with a professional. There are a whole series of means that were suggested that are interesting, that it would be interesting to explore. Then we have the question of costs. As I said earlier, it's not a major problem from the perspective of gay men. What we've seen in Quebec, in principle, everything should be free. But I can tell you that in Montreal versus the other three cities, it's in Montreal where you're going to pay the most for access to services, despite the universality of care. It's fascinating. We have work to do in that respect in terms of demands and advocacy. What I find interesting is that there are many organizations have found the way to lessen the costs. There are many different programs or subsidies or assistance to get your fees reimbursed, and all of that is in place. The last dimension, which is adequacy of services. This won't surprise you. What we've seen is an adapted service that meets our needs. We want corridors of services within different organizations or channels of services. We want to be reassured in terms of expertise and the quality of the teams that will be providing care, training and capacity building of staff and workers. I think James yesterday talked about this, and I've heard this said several times. Staff training is center. And yes, what we hear often, yes, I received training 10 years ago. Well, but from those that were trained 10 years ago, nobody is here anymore if training was off 10 years ago. So often it's the workers that are in direct contact. But the girl at the reception who has maternity leave and doesn't understand anything, doesn't understand the reality of the clients, so then you'll be lost. The person who makes an appointment and doesn't understand what you're going to tell them. So training needs to really deal with the whole chain. You need to be creative, maybe develop self-trainings on the reality of trans people, on the reality of bispiritual people. We need user-friendly tools that will be given to the receptionist and to the person receiving clients to make it a welcoming setting. I don't really have any more time. So a holistic approach, and I'll come back to this in my conclusion. So you've understood then what we've done with these indicators. It's really the desires of men wanting services. We'll be developing tools for that. If you want to improve approachability, we need to diversify the means and information. We need to have good geographical coverage because we've seen that even in the cities, services tend to be very centralized, and in the suburbs, in the outlying areas, there's nothing. And this also made us think about one-stop shopping, or one-stop shop, so that the information is relatively centralized with updates. And in terms of acceptability, really, we need to formalize and make explicit how confidentially will be maintained, and also within the space of the service provision. I don't have the time to say everything, but it doesn't matter. In terms of diversity, we need to talk about adapting fast-track users, self-service strategies. We see a lot of that in terms of screening, and it certainly does improve acceptability. Another thing that appears to be important is consistency. Consistency in approaches and in the staff that will receive you. If I have an appointment with Dr. X and in the next appointment I see nurse Y, it's not the best situation in terms of consistency. Affordability is really important. Really, advocacy is needed to make sure that retroviral treatment is all free, whether it's PrEP or PEP. There's a lot of disparity. And even in Quebec, it costs $90 a month. And when you're 17 years old and you're not out, the $90 a month is too much. These would be important measures. In terms of improving efficacy, we talk about one-stop shopping, better referrals to organizations with the tools I mentioned earlier, having clear protocols for follow-up. In the end, everything I'm saying is not terribly complicated to improve accessibility to services. We need to just think. There we go. I'll leave you on that and just remind you that what I'm telling you here, it's what the statistics, the data seem to tell us. There are people that have given the testimonies about all this, but what I'm telling you here is very urban. It's very white. It's only 3% were trans people. In Quebec, it's hard for us to access bispiritual people. It's just barely 1%. So these are some of the limitations. We talk about once we leave Montreal and we're in the outskirts, in the regions, then it's a different story. I appreciated the presentation yesterday on service provision in Manitoba because it underlines even more flagrant disparities. I hope I'll have time to hear you, receive your questions. But again, I want to ask you again for having allowed me over 30 years to go off track, to be there. And I hope together all of us can understand that research can also be a powerful tool. I'll be here all afternoon. I'll be happy to hear from you and to share with you. Thank you again very much for your openness.
people will still need them for which
I was just told that if you want to keep, if you're going to stay in this ballroom B, you'll still need your you'll still need your headset for some of the presentation if you don't speak the beautiful français.